Hi, Andrew Holden here, and I'm delighted to be part of this Shockwave Symposium, concentrating on the challenge of eccentric calcification. These are my relevant disclosures. We know calcification is a real challenge for peripheral arterial intervention, and that our standard endovascular techniques do poorly in the presence of calcium. Eccentric calcified lesions are particularly challenging because they're associated with less acute gain, but also they're associated with poorer outcomes. Often an angioplasty balloon will overdilate the normal side of the aortic or the vessel wall, as well as the ends of the balloon at normal vessels normal vessel ends where it gets overdilated, resulting in dissection, perforation, and incomplete stent expansion. Intravascular lithotripsy has shown promising safety and effectiveness in calcified peripheral arterial disease, but real-world evidence in eccentric lesions from a larger cohort is lacking. So we're going to review the real-world acute safety and effectiveness outcomes of intravascular lithotripsy in treating eccentric calcified peripheral arteries. To do this, we're going to review the findings from the Disrupt PAD3 observational registry. This was a very large patient registry that ran concurrently with the PAD3 randomized controlled trial. As you can see, just under 1,400 patients were studied, aiming to look at the real-world outcomes of intravascular lithotripsy for the treatment of calcified peripheral arterial stenoses from the aortic bifurcation to the distal tibial arteries. We're going to look at a subset or an interim analysis between November 2017 and June 2019, 752 patients, 852 lesions at 27 sites, and assess the real-world peri-procedural outcomes. Now, there is CallLab definition of concentricity and eccentricity. A concentric lesion obviously has disease on both luminal sides of the lesion, whereas an eccentric lesion has disease on only one luminal side, as you can see in this example. If we have a look at the baseline characteristics of this interim analysis, you can see that the majority of patients, 595, were concentric lesions, 157 eccentric, well matched in terms of comorbidities, although interestingly, there was a higher incidence of renal insufficiency in the eccentric patient group. In terms of symptom severity and Rutherford category, this was well matched between the eccentric and concentric patient groups. Now, if we have a look at lesion characteristics, there are some interesting findings. You can see that the severity of the stenosis in the concentric group was significantly greater. Obviously, to define an eccentric lesion, it needed to be patent, so there was no incidence of chronic occlusion in that group. The lesions in the concentric group were longer, as was the calcified extent of the vessel. But interestingly, in terms of calcification severity, it was well matched. If we have a look at the lesion location from the iliacs down to the tibials, again, well matched between the two groups. Now, if we have a look at some procedural characteristics, we can see that for concentric patients, the procedure time and the fluoroscopy time was longer, and that's a reflection of a longer lesion length. We can also see that the IVL pulses per lesion was more in the concentric patient group, again, a reflection of lesion length, but importantly, the number of pulses per millimeter of lesion was significantly higher in the eccentric group, reinforcing that these eccentric lesions require more active treatment with intravascular lithotripsy. If we also note, you can see 3/4 of the patients had lithotripsy only as the calcification modifying therapy, with around 1/4 of the patients also getting either atherectomy or a specialty balloon. Now, most patients had intravascular lithotripsy as a vessel preparation. with a definitive treatment after this with either a drug-coated balloon in the majority of cases or a stent. If we have a look at the angiographic outcomes, that then despite the eccentric lesions often appearing more difficult to treat, the residual stenosis after IVL and the final residual stenosis was almost identical in both patient groups with the corresponding luminal gain. So very pleasing angiographic outcomes, and also a very pleasing safety profile for both eccentric and concentric patients. In fact, no incidence of dissection, perforation, or distal embolization when treating the eccentric patient group with IVL. Now, there are a few tips and tricks to optimize outcomes when performing intravascular lithotripsy in eccentric lesions. One, as we mentioned, is to make sure we have more pulses per millimeter of lesion in the eccentric lesions to provide that fragmentation of the intimal and medial calcification and change the compliance of the eccentric lesion. The second is to ideally size, preferably at a size of 1.1 to 1, makes a big difference. And also we know that the acoustic pressure from the central emitters is more powerful than the more peripheral emitters, so we should position the central emitters opposite the most eccentric portion of the target lesion. Just some cases: in eccentric right common iliac artery stenosis in a patient with an abdominal aortic aneurysm. Intravascular lithotripsy was done to facilitate delivery of the device and sheaths. And although only a 7mm balloon was deployed, this changed the compliance of the right common iliac artery and allowed a limb to fully expand in this common iliac artery. Here's a case of a eccentric and heavily calcified common femoral artery stenosis. And you can see after intravascular lithotripsy, 2 plane views, an excellent result, some residual stenosis in 1 plane, but assessed at the core lab an overall residual stenosis of 24%. Here's another case of an eccentric stenosis as part of a longer lesion in the superficial femoral artery. You can see here treating the eccentric stenosis with the balloon at low pressure. And then as we start performing intravascular lithotripsy with no change in pressure of the balloon, we're clearly dilating, showing the fragmentation of the calcium and the change in vessel compliance, full dilatation, and an excellent result after this in a drug-coated balloon. And then finally, a tibial case. Here's a stenosis of the tibioperineal trunk, significant calcification. We use the S4 catheter here for the tibioperineal trunk intravascular lithotripsy with an excellent result. So this interim analysis from the real-world Disrupt PAD3 observational registry represents the largest experience of lithotripsy treatment for heavily calcified eccentric peripheral arteries. And the acute outcomes following IVL treatment demonstrated similar and significant improvement in diameter stenosis and mean lumen diameter following IVL treatment in both eccentric and concentric lesions with a very low complication rate. The treatment approach was obviously per operator discretion in this real-world study, but IVL was the standalone therapy in 3/4 of the patients. Most of the patients had subsequent treatment with a drug-coated balloon or stent. Certainly, future studies with longer-term follow-up are needed to understand the durability of intravascular lithotripsy treatment in calcified peripheral arteries. Many thanks for your attention.